Okay, cool. All right. Welcome everyone to the 2021 UNC Water and Health Conference. I am Anjadul Islam and I work for the Water Institute. Thank you so much for joining the session today with me. Um, can you go to the next slide, please? Yes. So before we get started, just quick announcement. We will have our networking and sponsor session event that will gonna happen at 3:30 to 5 Eastern Standard Time today in the afternoon. And please go ahead and join the session. We will, like last year, we will have the late early show. So people who would not be able to join the session throughout the day, it will just gonna be a recap of the day event. And our director, Aaron Salzberg, and Dr. Snehalata Mekala from the Freshwater Action Work will just gonna briefly share their experience and lesson learned to South Asia context. Let's quickly go through some technical instructions. Our session is being recorded. Um, and if you, but everyone but the verbal presenters will gonna be muted. And please, if you have any questions, please go ahead and type into our conference platform, Pathable, here, as is mentioned through the mouse by Elizabeth, our technical assistant. Um, with, yes, and without without any reason, we want to thank our sponsors, especially Bill and Melinda Gates Foundation, German Cooperation, GIZ, Washington School Network. For without them, it would not be possible to have this session. Without wasting any time, I just wanna introduce our first presenter for today's session. It will going to be Sarah Bick. She works at London School of Hygiene and Tropical Medicine as a research assistant. Um, Sarah, whenever you are ready, please feel free to share your screen and begin your presentation. You will have
Great.
10 minutes.
Thank you. Can you see my screen?
Yes.
Yes, great. All right, so good afternoon or evening, everyone. I'm very happy to be with you. I am a research assistant at the London School of Hygiene and Tropical Medicine. And on behalf of my colleagues at the London School, as part of the COVID-19 Hygiene Hub initiative, as well as RANAS and WaterAid, I'll be presenting emerging findings from our rapid assessment of the WaterAid COVID-19 hygiene response in multiple countries and the determinants of behavior change. So with the emergence of the global COVID-19 pandemic, WaterAid rapidly implemented hygiene behavior change programs in 28 countries, targeting key COVID-19 prevention behaviors. The initial hygiene response used a do no harm strategy and was delivered through multiple channels, including mass media, digital and social media, targeting over 100 million people in partnership with existing national campaigns. And this was followed by a subsequent behavior change phase. And recognizing the lack of real-time information on how these hygiene interventions were being received in the new normal context that COVID-19 created, WaterAid conducted a midterm assessment of their ongoing campaigns in late 2020 to understand the frequency of handwashing for COVID-19 prevention, as well as knowledge, motivational factors and barriers, and exposure to intervention campaigns. And I just want to stress that these are not the final outcomes of the WaterAid interventions. The purpose of this midterm assessment was to rapidly assess the ongoing effect of the first phase response in order to make some adjustments to the ongoing programming and to enable a future adaptive COVID-19 response that is sensitive to emerging drivers of behavior. So data were collected in 8 countries and 7 countries were included in the global analysis that I'm presenting today, which are Ethiopia, Ghana, Nepal, Nigeria, Rwanda, Tanzania, and Zambia. And country level analyses were also conducted in parallel for all 8 countries. Cross-sectional surveys were conducted between October and November 2020 for 15 days in each country in areas targeted by WaterAid's COVID-19 first phase response, sampling adults at the household level. A mixture of urban, peri-urban and rural areas was sampled, and data on COVID-19 prevention behaviours, potential determinants and exposure to interventions were collected via face-to-face interviews using mobile technology, and over 3,000 responses were included in the global analysis. WaterAid promoted 5 key COVID-19 prevention behaviours, including hand washing with soap. However, this presentation will focus only on hand washing with soap as the key outcome. So firstly, we used principal component analysis as a dimension reduction approach to identify primary outcomes of interest from self-reported data on the 5 key hand washing moments that were promoted as part of the interventions. And from this, we identified 4 distinct outcomes. The first outcome was a total of 3 key moments related to COVID-19 prevention after touching surfaces outside the home, when entering or leaving the household, and after sneezing or coughing. And then before eating and after toilet use were included as binary outcomes, as well as whether the respondent had reported having increased their own hand washing behaviour since the start of the COVID-19 pandemic, which was also a binary outcome. So for our first objective, estimating the prevalence of self-reported hand washing with soap, we found that at the global level, 83% of respondents reported practicing hand washing with soap after toilet use and 93% before eating. 80% of people also had reported increasing their hand washing behaviour in response to the pandemic. And these outcomes showed some variability by country. For example, the proportion of people reporting increasing their hand washing behaviour ranged from 52% in Tanzania to 95% in Rwanda. However, globally, respondents reported practicing only 1 out of 3 hand washing with soap moments related to COVID-19 prevention on average. And only 13% of respondents reported practicing hand washing with soap at all 3 moments that were included in the composite measure. However, 55% practiced hand washing with soap at least 1 of the key moments. This outcome was broadly similar across the countries with a couple of exceptions. So our main key finding was that hand washing with soap at the more established key moments, such as after toilet use and before eating, were reported far more often than the key moments specific to COVID-19 prevention. Next, we explored the relationships between the self-reported hand washing outcomes and behavioural factors using multivariable mixed effects regression analyses. Theoretically informed constructs of determinants were identified, and for factors comprising 3 or more variables, we conducted principal component analysis, extracted the first principal component, and rescaled this index from 0 to 3 to enable us to compare low, medium, and high levels of various determinants. Our regression models included random intercepts at the country and village or community level, and were adjusted for demographic characteristics and all behavioural determinants. Poisson regression was used for the key moments related to COVID-19 prevention, so you'll see a ratio of key moments reported, and logistic regression was used for the increase in hand washing with soap after the pandemic, for which we are reporting odds ratios. So for knowledge, we distinguished action knowledge as knowledge of hand washing with soap as a protective behaviour against COVID-19 for the respondents themselves or for others. And this indicator was associated with higher odds of the respondent having increased their hand washing behaviour after the start of the pandemic. And then procedural knowledge referred to knowledge of how to perform the protective behaviour. So in this case, knowledge of the key moments for hand washing with soap. And procedural knowledge was associated with a greater frequency of practicing key moments for COVID-19 prevention, as well as a reported increase in behaviour after the pandemic. Looking at barriers, a significant barrier to frequency of hand washing moments for COVID-19 prevention was the respondents' reported lack of self-management, such as forgetting or being too busy for hand washing with soap. And lack of water access was a significant barrier to the respondent having increased their hand washing behaviour after the start of the pandemic. The water aid programming leveraged emotional drivers and motives of behavior beyond fear of COVID-19. And in regression analyses, we found that as well as fear of COVID-19, the motive of protecting others from COVID-19 positively predicted the respondent having increased their hand washing behavior in response to the pandemic. So our key findings were likely determinants of self-reported hand-washing behavior, where that barriers related to self-management and water access were significant predictors of hand-washing with soap. Protecting others and fear of COVID-19 were significant motivational factors, and knowledge of key moments for hand-washing with soap predicted self-reported hygiene behavior. And for our final objective, we explored exposure to intervention activities. And we found that the vast majority of respondents reported having been exposed to any COVID-19 prevention message, about 94%, and around 90% reported having heard specific messaging promoting hand washing with soap as a key preventive behavior. And in regression analyses, we found that exposure to specific messages on hand washing with soap, as opposed to general COVID-19 prevention messages, was associated with over 3 times greater odds of the respondent having increased their hand washing behavior, and a significant increase in the reported number of key moments related to COVID-19 prevention at which hand washing with soap was practiced. So some of the key implications of our findings are that future COVID-19 responses should be adapted to make sure that they demonstrate the critical moments for hand washing that are specific to COVID-19 prevention. These key moments are less established than hand washing after toilet use and before eating, and should be a key focus of ongoing programming. And intervention should seek to improve people's self-management to facilitate hygiene behavior, and intervention should continue to target key motives of behavior beyond fear of COVID-19, particularly the strong motive of protecting others in order to improve and sustain hygiene behavior for the prevention of COVID-19. So thank you very much for listening, and I'm happy to take any questions.
Wow, that's a good presentation, sir. Please feel free to use the passable chat platform to ask any question to Sarah. Okay, we have some questions coming in. It's from Colleen. She asked that, are there plans for longer term follow-up to see if trends still continue longer after training?
So I think for this question, I'd have to defer to our colleagues at WaterAid, who I think are on this call. Maybe they can answer in the chat. But yeah, I believe there are plans to see what the longer term outcomes are of the overall WaterAid COVID-19 response. But this cool. This particular analysis was a kind of rapid assessment to take a snapshot of the kind of ongoing effects at the time in order to make some quick changes. And obviously, this kind of intervention would benefit from understanding what some of the long-term effects are of these behavior change programs.
Oh, great. Okay, as people are typing in, I could ask one question as people are typing in. So what kind of regression models did you run for this analysis? Is that logistic regression or linear regression or something? Yeah. And why did you choose that model?
I can go back to that slide. Yeah, so we used mixed effects regression analyses in order to account for the clustered nature of our data, and we used different models for each outcome that we included. The majority of our outcomes were logistic models because they were binary outcomes, and then for the indicator for hand washing with soap for COVID-19 prevention, which was a really account of the number of key moments mentioned, we used a Poisson model for that. So the coefficients that you see are kind of a ratio. So procedural knowledge was associated with the respondent mentioning twice the number of key moments.
Got it. Thank you. I'm monitoring the chat, but we're still waiting for people to pop in with any question. I think my another question. Oh, okay. We got another question. Oh, we got a couple of questions. Great presentation from Johnny. The self-management barrier seems to imply that nudges like visual reminders might improve hand washing frequency. Was this research just among households or also healthcare providers?
Yep, so this particular research data were just collected at the household level, but yes, we agreed that this finding of self-management being a significant barrier would suggest that having some sort of nudge or visual cue would really help to make sure that that behavior that they're given reminders and that it would cue that behavior, and also allow these behaviors to be sustained as we're going through the pandemic and beyond. Yeah.
Great. We have time for one more question, and we will take the one from Hugh. And the question is, the findings about positive motivators are really interesting. Why are you surprised?
No, I mean, I think probably not very surprised. I think we expected that fear of COVID-19 would be a big motivator, but belief that hand washing with soap protects others being a significant motivator, I think is a positive finding. It's a kind of positive motivational driver that can be really leveraged in future campaigns. So yeah, not too surprising.
Okay, cool. Okay, Sarah, thank you so much for your presentation today. We have some couple of questions coming in. After the presentation, we will really appreciate if you can go to the Pathoball and ask any question that's not answered during this call.
Happy to answer in the chat. Thank you very much.
Thank you. And would you mind? Yeah, thank you so much. And now we'll move on to our next presenter. Our next presenter will be Dr. Ian Ross. He works as a research fellow at London School of Hygiene and Tropical Medicine. Dr. Ian Ross, whenever you are ready, please feel free to share your screen and start your presentation. You'll have 10 minutes. Thank you.
There we go. Right. Okay, can you see my screen, everybody?
Yes.
Okay. So hi, my name's Ian Ross from London School, and these listed on the screen are my co-authors from WHO and UNICEF. And I'm just starting my own timer. Right, so this presentation is about costs. It's about costs of hand hygiene. There's a preprint available. I've just put the link in the chat box and the questions. So that has much more detail on the methods than I'm able to provide in 10 minutes. So the background to this is that we know there's many people in these developed countries, LDCs, who don't have hand washing facilities. We've used the JMP definitions for this, no facility, limited and basic, they're on the screen. And basically in this costing model, what we're trying to do is look at the cost of moving people from no facility to basic. So where they have no hand washing facility at all, to a situation where they have a facility and they have soap and they have water. There's very few data points for various components that make up the cost of hand hygiene, as I'll explain shortly, because I tried to find them. But there's also an issue with broader budget and expenditure data on hygiene. There's far fewer data available for those variables for hygiene than there is for water and sanitation, as you can see in the second bullet there. That's from the GLASS report. So we have basically an evidence problem here. So we decided to delve deeper in to find out what we could do with the data that is there. There was a previous study which touched on this, Hutton and Verghese in 2016 at the World Bank. There's 4 limitations of that we've built upon, and Guy Hutton's one of the co-authors on our study. Firstly, in that study, they didn't have any specific hygiene-specific estimates of costs for total or recurrent there. Only the capital was reported. Secondly, they assumed something about the promotion and what the facility looked like, but didn't really describe that or sort of do any sensitivity on that. And they only had 5 peer-reviewed data points for the promotion side, whereas we've managed to identify 14 in the subsequent years and through doing more searches and more contacting investigators of impact evaluations. And finally, they did sensitivity analysis, but it wasn't specific to hand washing. So we've explored many more of the assumptions that are hand washing specific in this study. So the aim is to estimate the economic cost of universal access to basic hand hygiene and household settings in those 46 least developed countries. I underline those things, economic, because that's what we're doing is the value of all the resources which are used, even if they're not paid for, and no matter who pays for them. Universal, because it's for everybody without the facility, basic for JMP, and household, because we're not covering schools or healthcare facilities here. Why are we doing this? To facilitate discussions of plans. This is part of the Hand Hygiene for All initiative that WHO and UNICEF are running at the moment, and also to compare that number, whatever the number is, to other investment priorities to see how big it is, how big the problem would be. Things I'll cover in the discussion section are water effectiveness and who pays. And water is a massive issue for hand washing, obviously, but in this, and this is hand washing with soap that we're looking at, we do include the recurrent cost of water, but we don't include the capital costs of water supply for people who don't have it already. So that's a massive additional cost that might be necessary, which we don't cover. Effectiveness, in costing studies like this, the aim is normally to scale the cost of scaling up the intervention to reach people, rather than incorporating any estimate of how effective that intervention would be in uptake or changing behavior or sustaining behavior. So those are key things, actually achieving hand hygiene for all, but those would be the uptake and sustainability, but those would be incorporated in a cost effectiveness, cost benefit study, and they're not incorporated in a costing study like this. So skipping straight into the intervention, we're modeling the scale up of an intervention to all those people without a facility. The intervention that we assume in the base case, which is our headline results, is there's some formative research that happens to see what's going to be most effective. And then there's 3 arms to the intervention. There's one-to-one household visits, someone going to a house and promoting things. Then there's group activities like theatre or community meetings and so on. And then there's mass media, TV, radio, adverts. This was driven by sort of normative best practice in the sector, as well as the cost data we had available. We also model an alternative scenario where we exclude the one-to-one visits, and that dramatically reduces the cost, as you'll see shortly. In terms of the facility, we assumed a 20-litre drum with tap, purpose-built, that's assumed to last 5 years, more or less like the middle picture here. And the alternative case that we modeled was more of a tippy-tap style thing, a much simpler piece of technology that only lasts 2 years, to see how that changes the cost. So when we're cost modeling, what we want to do is end up with this total cost over 10 years between 2021 and 2030. And to get there, we multiply quantities by prices. So the quantities are from JMP and the prices are from academic studies. And what it means, straight line scale up there, is that let's say there's 1 million people that we want to serve. It's more than that, but let's assume it's 1 million. We're breaking them into 10 equal chunks. So we serve 10% in year 1, 10% in year 2, and so on. So the quantities come from JMP, and we convert that into the number of households we want to serve by urban and rural using DHS data on household size. For prices, this is all coming from academic studies, from searches, from me pestering impact evaluation investigators. Thank you to those I see listed in the attendees, and from the Hutton study. The ends there are the number of studies which underlie each estimate for each of these 6 cost categories. So we managed to get 14 for promotion, which is possibly the most important one in terms of what it would cost for governments to do things. So along with quantities and prices, we need some economic data to basically mix all those disparate sources of data from different years, different countries, to make them comparable. So PPP factors is about purchasing power, making things comparable between countries to international dollars. GDP deflators is about time, and the foreign exchange is to get things into US dollars. So what we do is first convert all the prices from each different studies into 2019 dollars and then convert that to international dollars and take the mean of the international dollars. So that's basically saying if you have 5 studies, take the mean of the international dollars, and then you get the standard error of the mean. And that basically gives you an estimate that you can use for sensitivity analysis. That standard error is very important. And then you convert it back into US dollars so that you end up with a price for each country and a mean, sorry, a price and a standard error for each country. So that standard error goes into that red box, the Monte Carlo simulation, where you're drawing 1,000 times from a model to get the 95% confidence intervals. This is the input price data. The main message of this slide is that the orange one is the promotion in the base case. That's where we include the 1-to-1 promotion. So there's n equals 7 there, and there's n equals 7 in the white box, which is where you exclude that. And the message in the orange is that there's massive uncertainty in that promotion price there, which we incorporate in the sensitivity analysis. This is the result. So the kind of takeaway headline is 12 to 15 billion over 10 years to get hand hygiene for all for people with no facility in LDCs. The bulk of that, or the biggest piece of it, is soap. Recurrent soap costs are a lot, but promotion is also important. If you combine the 2 promotion bits, the initial promotion and the top-up promotion, that's about 42%, about 5 to 7 billion. Initial promotion is the kind of one-off big campaign that happens for everybody, and the top-up is a 25% follow-up that happens annually after that for everybody. I can get more into that in the Q&A if people want to. I won't go into the alternative scenarios, but they're there on the screen. Basically, excluding 1-to-1 halves the promotion cost. And if you're promoting to everybody and not just those without a facility, then you triple your promotion cost.
1 minute.
Here's the results over time. What I would really emphasize here is that the capital costs are more or less similar. That's the orange is more or less similar, whereas the recurrent costs rapidly escalate over time because each new cohort of 10% of the population is incurring those each and every year. That's why soap ends up being so big. Now, discussion. So who pays? I think my assumption would be that the government is going to be paying, with support from donors, hopefully, in these countries for the promotion costs. So that's about $0.50 per capita. And that's about 5% of health expenditure, government health expenditure in those LDCs. So it's a lot, but it's possibly achievable. Water supply is a massive issue, as I said at the beginning, and it's a limiting factor for half of the people who have the limited service. Economies of scale are important. This graph on the right is a tornado plot. Basically, the things at the top are the things with the biggest uncertainty around them. And economies of scale, if we incorporate some assumptions on that, which I can't go into now, but are in the paper, then that does reduce the cost a lot. And effectiveness, I mentioned, we need more studies of cost benefit and cost effectiveness of hand washing interventions. So thank you very much for your time. The main takeaway I'd like to leave you with is that it's about $0.50 per capita per year to get this done from a promotion perspective. And it might well be lower with economies of scale or including more messages in the intervention. So this can be achieved, but it will need a higher level of ambition, both from government and partners. Thank you very much.
Oh, thank you so much, Dr. Ross. As people are trying to fill up their questions here on the Pathable, let me start with the one. So we have seen that 1-to-1 household visits has a great role in terms of the promotion. Do you think if you are looking for if you want to include so in your study you included, I don't know, maybe around 47 countries, but if you want to scale up to large level, would that be feasible?
So the rationale for the 47 countries was really because a similar study had just happened for healthcare facilities, and we wanted them to be directly comparable, but also these are the countries generally in most need of support. So it's not so difficult to add more countries because all you're doing is applying a mean. We're taking that international dollar mean and applying it to any country. So in the cost model, which I didn't mention, there's also a costing tool, which WHO have on their website, which I made from this, which far more countries, I think it's more like 100 or so, can produce results there. I'll try and find the link after I've finished and put it in the chat box. And yeah, so basically the short answer to your question is it's very easy to add more countries because you're just applying a mean and a standard error to any country.
Okay, thank you so much. We have a question from Johnny. Good research for those for doing proper sensitivity analysis and reporting confidence interval. What sort of costing data do you think would most increase the accuracy and precision of your estimates?
Thanks, Johnny. Great question. I think this box plot, I think, is what I'd point to. This orange, I think the biggest source of uncertainty in the tornado plot at the end was the promotion price, and that's this orange bar here, where we've got a range from less than $20 per household. Look at this y-axis here, cost per household in 2019 international dollars. So it will be a lot cheaper than this in some countries, all the way up to 200. So it's a factor of 10 difference here within this data, huge uncertainty. So in any given country, this also reflects the characteristics of the interventions being slightly different. That's all kind of bundled up in this bar as well. So really, what we would encourage people to do is look at what their specific intervention would cost in their country, and cost that, because it will be far more accurate and precise than what we've done here by sort of melding together many interventions from many countries. But what we do in the study is kind of give that ballpark idea of what sort of cost might occur from for this kind of intervention. I think the other thing is around soap. The soap expenditure, because it's a third of the total, even though it's slightly more, smaller standard error relatively to the promotion, because it's a third of the costs. I think it's important that more and more studies which are done of hygiene interventions or otherwise collect data on how much people are spending on soap for hand washing. Only 10 studies we found have reported that. And imagine how many hygiene interventions have happened in the last 10 years that could have easily collected that information. It's an important financial cost for households to incur that soap expenditure. And the glass data and the TRACFIN data that WHO produced does really show that's important for people. It's a substantial cost, often similar to water. So yes, I would argue that better promotion cost data and more collection of soap expenditure data.
Okay, cool. We have another question coming in from Julia, and Julia asked that I think you were talking about the limited evidence on the hygiene dimension in comparison to water and sanitation in the JMP report.
Yeah,
sorry.
So I can see it on the screen, so I can jump in.
Okay, cool.
So I wasn't talking about the JMP data. I was talking about the cost. So I was talking about the GLASS reports, and GLASS is something that WHO does every 2 years about policy and finance. So basically, only 16% of the countries which reported to GLASS could say how much they'd budgeted or spent on hygiene, whereas more or less half the countries could say what they'd budgeted or spent for water or sanitation. So basically, we don't know how much anyone's spending on hygiene. That's the problem there. I think in the interest of time, let's move on to Brian's question, and you just stop me, Andrew, when we have to stop.
Yeah, so, I think we need to move on. Sorry.
Right. I'll respond in the chat by text.
Yeah, that would be great. Thank you so much. Okay, our last final presenter for today's session will be also from the London School of Hygiene and London International Development Center, Professor Hugh Sharma Waddington. He works as the assistant professor at LSHTM. Professor Hugh, whenever you are ready, please share your screen and start your presentation.
Great, thanks, Andrew. So I'm hoping I'm sharing my screen.
Yeah, you are showing the correct one. Thank you.
I'm showing the right screen, yeah?
Yeah,
okay.
Yeah.
Okay, great. So thanks to my co-panelists and also to everybody in the room for attending this session. What this presentation is really about is making better use of existing evidence, and particularly evidence which comes from studies that they tend to be quite expensive, some of these studies. So obviously it's a zero-sum game. The amount of studies we do takes money away potentially from programming. So let's make better use of what we already know. And what I'm going to do is present a systematic review meta-analysis results from a systematic review. We published the protocol in Campbell's Systematic Reviews at the end of last year, and that is on the whether water, sanitation and hygiene save lives. And we also present some implications for the global burden of disease estimates. I'd like to acknowledge my co-authors, one of whom is on this panel, that's Sarah Bick, and also Sandy Cairncross. Okay, so we were asked to really situate our presentations in the policy literature, and this is where it was really the policy literature that started my interest in this topic, and in particular the global burden of disease. So what is shown here is the global burden of disease estimates provided by the World Health Organization. You can see that there's estimated around 1.5 million deaths, which are attributable to inadequate wash every year, about half of which are from diarrhea, and about another quarter are from respiratory infections. So that's around 800 dead kids every day from inadequate wash, and I think we should all remember that every single death is a personal tragedy to the carers of those children. And how is the global burden of disease calculated? Well, it's based on disability adjusted life years, which is the daily, which is the sum of the years of life lost, which is the number of deaths in the population due to water-related infection multiplied by the life expectancy at the age of death. So obviously that's going to be greatest amongst children, and most of the deaths are amongst children. And the second component of this calculation is the years living with disability, which is based on the number of days experiencing, in the case of diarrhea, for example, diarrhea is much smaller in outside of outbreak situations. So in endemic circumstances, we might expect a child in a low-income context to suffer from 3 bouts per year. So what you can see is that the daily estimates, they're massively stacked towards years of life loss, and you can see for diarrhea, for example, 90% of the DALYs are due to deaths mainly in childhood, and for respiratory infections, it's around 99%. What are these figures based on, and what are some of the issues that with these figures that we're trying to rectify in this research? So first of all, what is well known in the health impact evaluation literature is the bias due to reporting, and so that includes even or possibly we might say especially prospective studies like randomized trials and so on. There is an issue which is well known. Some people call it participant fatigue. Excuse me. Tom Clarkson called it the bugger off effect, and that's essentially the issue where the more times that you go and visit and take the time from survey respondents, if they're self-reporting that an illness, they might just tell you after a certain number of visits that no, everything's fine, so bugger off. There's a second issue, so that's the issue with reporting bias of morbidity. The second issue is indirectness, that essentially the global burden of disease estimates are mainly based on morbidity, because studies are only, it's very difficult to power a study statistically, particularly a prospective study, to collect mortality. So even though we might be interested in mortality as the primary outcome, we're kind of stuck with the morbidity estimates. So there have been some innovative solutions proposed. One approach used, which was originally proposed by Paul Hunter, which is used by the WHO group, is to use Bayesian statistics. And an approach that we're presenting here is to essentially go the direct way, which is using data on mortality. And the reason why we think that approach is a good one is because mortality is known to be less susceptible to reporting bias. So there's epidemiological studies which have shown that. And like those, but we still have this issue of the rareness of the outcome, and so the statistical power issues with single studies. So of course, like everybody, we use meta-analysis. So this is an example of a study in South Africa which reports all-cause mortality. This is, and it's what we're showing here is a participant flow diagram. So all good trials report participant flow diagrams or report the information in which that can be obtained. And they do that by study group. So we can see the deaths. They're supposed to give the reasons for dropouts, for example. Sometimes they give it by age group, and sometimes you even get cause of death. But usually it's all cause mortality. So our proposition is for some of this analysis we harvest those data. So what's the big issue? I've mentioned power about 4 times already. The big issue is in power. So in this study there were only 4 deaths. So you find that if you were to present a forest plot, which we've done for the two trial arms in this study, we get an effect which is not just statistically insignificant, but it overlaps with approximately 0 and 1,000. So in other words, we're going to need a lot of studies in order to do this. The good news is that we produced a evidence and gap map, which my colleague Hannah presented here, I think last year. It's coming out in Campbell's systematic reviews in the coming weeks. And where we obtained all of the, or what we hope is all of the WASH impact evaluations that have reported various outcomes, and we're just focusing on mortality in this specific case. So I'm just going to focus on the findings now. There's an entire systematic review that underlies this presentation. So there's a lot of information about how the data were collected, what the interventions were, how reliable the studies were, and the bias and so on. But this is the headline finding for all-cause mortality in childhood. So what we're actually seeing is when we look at all-cause mortality based on these studies, we see overall a 15% reduction. There are some. We can also look at subgroup analyses by WASH technology and WASH intervention, but overall we see a 15% reduction in all-cause mortality. We think this is very likely to be an underestimate, as the data are collected from crude mortality rates rather than infant mortality per 1,000 live births, because those data would follow the child over the full 0 to 11 months. So these data are censored, so they're likely to be underestimates. It's worth noting that there's only one single statistically significant estimate in this forest plot. So this kind of shows the power of meta-analysis in pooling across studies. This is the finding for diarrhea mortality. So diarrhea mortality would be estimated in these studies through vital registration or verbal autopsy, and sometimes those verbal autopsies would be verified by a clinician. And we see a very large reduction of 50% in mortality due to diarrhea, and this is we would expect that this mortality reduction to be bigger than the one for all-cause mortality, because WASH is the leading cause of diarrhea illness.
1 minute left.
Right. Okay. So a couple of slides that just demonstrate that we think these findings are unbiased. This is a couple of funnel graphs. Essentially, there's a dashed line that goes down the middle. If we anticipated that the findings were subject to publication bias, we wouldn't see this dashed line going down the middle like this. And nearly all literatures have publication bias. It's just how the publication system works, and we don't see publication bias in this literature. Second of all, an example of what we've called a negative control. So in other words, would we expect to see a reduction in all-cause mortality amongst adults? And we wouldn't do, because we wouldn't expect, because of the we expect to see the reductions amongst children because of the weaker immune systems that we wouldn't expect to see amongst adults. So what are the implications for the global burden of disease? Essentially, we've calculated figures by wash technology. Then we use the WHO method to calculate the population attributable fraction of disease, which we've applied, and we've estimated that there are between a million, 1.2 and 2.1 million diarrheal deaths per year due to wash. So that's about as much as 1.5 million more than current estimates, and many of these deaths are in the Africa region. Final point. This is essentially, we've relied on reporting in primary studies in order to do this work, and you can see this figure shows that there's about half of the studies reported in environmental health report participant flow diagrams. Very few do in the social sciences. Reporting has improved over time, but this is really a plea to trialists to report your participant flows. We are hoping to obtain funding to follow up this work to reanalyze the individual participant data sets. And so if you want to join an author collaborative to share participant data and save lives, please contact me. Thank you.
Oh, thank you so much, Professor Hugh Waddington. We have a good comment coming up from Brian. Thanks for flagging up the ethical issues of the opportunity cost of repeated research, diverting resources from interventions. We have one question coming in from Rick Johnston. Rick asked that, really interesting analysis. Did you look at the links between mortality and water, sanitation, and hygiene separately?
Yes, so Rick, good question. I think part of what was motivating this was to look at the. I hope I've understood your question correctly. Part of what we were motivated by was the fact that, when you have, part of the reason why the findings don't suggest that there's any additional effects of combining water, sanitation, hygiene interventions. One explanation for that is the bias in reporting. And so what we have done is looked at individual and combined impacts, and we do some sensitivity analysis and report on those. I think it's important to point out that we estimate the biggest reductions in child mortality are due to wash are from improved community-wide sanitation and hygiene.
Wow, thank you so much. We don't have any more questions coming in right now. I just have a quick question regarding the Bayesian statistics. Can you say briefly what is that? I don't, yeah. Or how did you do that? Yeah.
Okay, so it's not actually what we did. We did something else, but I know there are people in the room that actually use the Bayesian approach. It's essentially, if you imagine that in a kind of a standard, if you like, meta-analysis approach, we have two or more estimates of mortality reductions due to wash. And those are all from particular points in different contexts, different countries. In the Bayesian approach, it kind of says, well, rather than just averaging across those, why don't we incorporate a prior? And that prior is basically what we would expect based on, the fact that in this case we think that the diarrhea morbidity data are biased because of this bugger off effect. And so essentially what the Bayesian approach does is draws on a prior, and that prior was based on a meta-epidemiological analysis that was done. That it didn't incorporate any wash studies, so there were some concerns about whether it was appropriate to incorporate it, given that a lot of the evidence was clinical rather than in a field setting.
Wow,
that's my understanding of it. Yeah.
Oh, cool. Thank you so much. We have another question coming in from Brian, and I think that's the last question that I can take at the moment. The headline figures are used by the WASH sector. Do they have much attention in the wider health sector?
I'm not sure. I'm not sure. I fully understand the question. The headline figures for the global burden of disease are very widely used in WASH, and in the global burden of disease estimates that I've seen, which are broader and very broadly health. I think they also incorporate those. I think there are different groups working on the global burden of disease, and I'm so I defer to I think there are various different estimates out there.
All right. There's another question. I believe you mentioned briefly at the end of your presentation, but how much different are these results from those reported in all-cause studies like DCCP?
Yes, disease
Sorry,
controls
DCPP.
priorities. Okay, so that's a really good question, and that actually gives me a great comment that I can now incorporate when we're writing up the paper, because we're currently writing it up, and so we'll have a look into that, and hopefully we'll be able to report on that. So thank you, Lewis.
All right.
So broadly, I think our results are in line with what my colleagues have been from LSHGM have presented on this panel, and with the disease control priorities that we're seeing a lot of impact of hygiene interventions.
Okay. We don't have any questions coming in right now. Well, thank you so much all for your presentation today. I really appreciate that you took the time to present your work. It seems like you are doing really great work. I'm just wanna briefly mention that we will have our posters. So all the audience, please stay tuned. So here we are just seeing a purple color, quick, very nice view, which is great. I really like that. I like the calmness of that. So, and also we'll have our networking event in Remo, which is gonna happen from 3:30 in the afternoon today in Eastern Standard Time. And we all have, so you can find the details of the registration through Remo in the website. And last but not the least, I really want to thank our sponsors. Without their support, this event would not be possible. So thank you so much all. Have a good night, evening, morning, day. Yeah, thank you. Bye, everyone. All right, you guys, if you wanna guys hang out, you can guys hang out. But the session is gonna end at 2:35 or something. And I have to go because I have another session. But thank you so much.
Thanks,
Appreciate
everybody.
it.
Thanks for sharing.
Thanks, Andrew.
Andrew.
Yeah.
Thank you very much.
Well done.
Bye.
All right, bye.
Bye.